Good evening, everyone. My name is Michelle Leroux. Today I'll be presenting my case. My case title is Abnormal Uterine Bleeding with Chronic Blood Loss Anemia in the Primary Care Approach. Now, the first thing that I'm pretty sure it came out in your mind is why in the primary care? Why she didn't went to a gynecologist? Well, she came to her primary care. And we're going to evaluate, we're going to diagnose, and we're going to manage, and we're going to follow up. This patient is a 56 years old female. We're going to call her MA, that's her initials. Presenting with persistent uterine bleeding and associated complications. Now, what is our job as a primary care provider? Very not easy, but it's our job is to identify the underlying causes and why she's bleeding, manage the symptoms, prevent complications, and coordinate care like gynecologists, send her to the ultrasound. In this case, our priority, our main priority is to control the bleeding and treating the anemia and infection and ruling out everything else after that, such as endometrial hyperplasia or endometrial cancer. So what are we discussing today on this presentation? We will review the patient history. And when I say patient history, it's not just a little bit, okay, let me check what she's doing right now. No, we're going to discuss her past medical history, her social history, obstetrics history, gynecological history, medication history, anything that can be related to today's visit. Okay, we also going to evaluate our treatment, our monitoring, our discussion of the clinical significance of abnormal uterine bleeding in older women. What we know about this patient, Miss MA, she's a 56 years old female who presented to our clinic with heavy vaginal bleeding, pelvic pain, dizziness, weakness, and symptoms very consistent with blood loss anemia. So what is our main chief complaint? Patient came in and she was having bleeding for about 4 months, have a lot of pain, dizziness, and very weak. Now what we do? All right, so Miss MA, 56 years old female, history of endometrial polyps, chronic endometritis, hypertension, hyperlipidemia, came in today with 4 months of heavy bleeding, passage of large clot, frequent pad changes. Now she also experiencing fatigue, palpitation, shortness of breath with exertion. Her age, her obesity, her prolonged symptoms is telling me that something is going on with her endometrial pathology. So let's get to know MA a little bit better, right? Current meds, she's on lisinopril for hypertension, atorvastatin for hyperlipidemia, ibuprofen 200 milligrams for pelvic pain, which is not very helpful, and it's a very low dose. Multivitamins. She's married. She doesn't smoke. Drinks occasionally. Has 2 pregnancies all the way to full terms and vaginal delivery on both. When we come to contraceptive, she has tubal ligation and oral contraceptive she was taking to control the bleeding. Okay. So her gynecologic history is significant for metometrorrhagia, lasting for about 4 months, severe pelvic pain, passage of large blood clots. She also has history of endometrial polyps and chronic endometritis. Now, we know this patient has hypertension, hyperlipidemia, she's obese, has iron deficiency, past surgery, tubal ligation, hysterectomy with endometrial polypectomy. Okay, so let's review ROS. She's positive for fatigue, dizziness, weakness, pallor, palpitations, and pelvic pain. Now, what this tells you? It tells you that it supports chronic blood loss and anemia. Okay, so 2 things. Oh, let me just say it like this. During an examination, the patient appears very pale and fatigued. Vital signs were stable, some tachycardia, about 1 or 2, 1 or 3. Now, during pelvic examination, there were some adnexal tenderness, and malodorous discharge. Now, this is kind of suggesting that there's some type of chronic inflammation going on. Now, also, all this paleness support anemia. Let's see what else. Okay, diagnostic. What we did lab work. We did everything in the clinic. We did infection screening. We did pap smear. We sent her to get an ultrasound, transvaginal ultrasound done. We also sent her to see a gynecologist for a referral. All right, so what's the primary diagnosis? I have 8 minutes. So, primary diagnosis is metametrorrhagia. Secondary diagnosis, iron deficiency anemia, chronic endometritis, endometrial polyp, and bacterial vaginosis. Now we have to check what else we need to rule out. It's endometrial hyperplasia, endometrial carcinoma, and uterine fibroids. Okay, class, so what does this case demonstrate? It demonstrates that anything can happen in the primary care setting. It's important to evaluate cases like that, like abdominal uterine bleeding in women over 45. While this might be benign, we need to rule out what's the possibilities and consider all the if. Now, early diagnosis is always essential to improve the outcomes in patients like this. So what is the plan for MA? We focus on controlling the bleeding, correcting anemia, treating infection, and reducing pain. The patient received hormonal therapy, iron supplementations, antibiotics, antifungal therapy, and anti-inflammatory medication. Okay, so what's next? Pending orders. We have transvaginal ultrasound, a repeat CBC, a repeat iron study. The patient was referred to gynecology for hysteroscopy and endometrial biopsy. She was scheduled to return to the clinic in 1 week for reviewing the labs and the ultrasound. So patient education focused on medication adherence, increasing dietary iron intake, maintaining hydration, monitoring bleeding patterns. Emergency precautions were reviewed, including when to seek immediately medical attention. All right, so primary care takeaway. This experience reinforced the importance of early detection, patient education, and timely gynecology referral to improve outcomes, improve complications like severe anemia, preventing transfusion, endometrial hyperplasia, or endometrial cancer. Now, for me, it's strengthening my confidence in managing women's health concerns within the primary care setting. At this time, I invite everyone to select 2 discussion questions and apply evidence-based clinical reasoning to the patient's presentation, diagnostic finding, and management plan. Okay, here are the questions. These questions are designed to encourage critical thinking regarding abnormal uterine bleeding, anemia, cancer risk factors, diagnostic evaluation, and the role of primary care providers in early detection and management. Every heartbeat tells a story. As a future nurse practitioner, we all should be committed to listening, healing, and leading. This case reinforced the importance of comprehensive assessment, patient education, and timely intervention. This is the end of my case. I hope you enjoy it.